Good morning, everyone. My name is Dr. Rebecca Sullivan. I'm a postdoctoral researcher with the Aphasia CRE, and I co-host this series with Dr. John Pearce. Before we begin, I'd like to acknowledge the traditional owners of the lands across Australia and pay my respects to elders past and present. I'm joining you today from Wurundjeri country. I extend that respect to all Aboriginal and Torres Strait Islander people here with us today. Today, it's our privilege to hear from the newly minted Dr. Chelsea Larkman. Chelsea will be presenting her work Beyond Language Barriers, from challenges to collaboration in interpreter-supported cross-linguistic aphasia therapy. Missed that one. So, all right. So before we begin, as a quick reminder, if you have a question, please type it into the Q&A box at any point during the presentation. Don't hesitate to add your thoughts as they come up, and feel free to upvote any of the questions you'd like to see answered, and we'll aim to cover as many of them as we can in the discussion at the end. So it's my great pleasure to introduce Dr. Chelsea Larkman. Chelsea is a senior speech pathologist and early career researcher with extensive clinical experience working with adults with communication and swallowing difficulties across hospital and community settings. Chelsea completed her PhD at, oh, goodness me, all my buttons are going off today. Chelsea completed her PhD at La Trobe University with the Aphasia CRE, examining cultural and linguistic adaptation of aphasia rehabilitation. She used, oh goodness me, phenomenological and co-designed research approaches to explore the challenges and potential solutions to cross-linguistic aphasia therapy from the perspectives of both speech pathologists and interpreters. Chelsea's PhD was motivated by the barriers she encountered to providing equitable aphasia care for people with aphasia from culturally and linguistically diverse backgrounds, and adapting aphasia therapy approaches for delivery across languages and cultures. Chelsea is currently working as a postdoc research associate at the University of Sydney and is affiliated with the Aphasia CRE. Thanks, Beck. I'll just get my screen share up. All right. So, yes, thank you for that introduction, Beck, and thank you to the CRE for the invitation to present today. I've watched the seminar series for a few years now, and it's a real honour to be on the other side of the screen. So I was very lucky to do my PhD with Professor Miranda Rose and Dr. Lucy Lanyon. And like Beck said, it explored cultural and linguistic adaptation of aphasia rehabilitation with a strong focus on speech pathologist and interpreter collaboration. I'd just like to acknowledge the traditional owners of the lands that I lived on whilst I was completing my PhD. Here in Sydney, it's the Gadigal people of the Eora Nation, and whilst I was living in Washington State for a couple of years, I was on the traditional lands of the Nisqually tribe of the Coast Salish people. So the background and motivation for my PhD research did stem from my clinical work here in Sydney, where I worked with clients from diverse cultural and language backgrounds with whom I didn't share a language, and the challenges that I faced trying to adapt aphasia therapies into other languages. And this scenario of needing to deliver aphasia services to clients who speak different languages and come from different cultural backgrounds is becoming increasingly prevalent due to patterns of international migration. Here in Australia, our last census data from 2021 told us that more than half of our population were either born overseas themselves or have one or both parents born overseas. And more than a fifth of our population use a language other than English at home. And after English, our top language here in Australia is Mandarin. If we look at the US data, we see a somewhat similar picture. So 22% of people aged 5 and older speaking a language other than English at home. And after Spanish, you can see there are some similarities between Australia and the US in terms of the top 5 languages.
I've got one more set of data. England and Wales's data is reported slightly differently because their question is worded differently. They ask people what their main language is. And so in their last data, they found that 8.9% of people speak a language other than English or Welsh as their main language. And looking at the top 5 languages spoken after English, we've got a different story there in the UK. So Polish is the top language there. So that's just a handful of stats for a few countries, but I think that those stats really highlight why it's important to be talking about cross-linguistic aphasia therapy, particularly when we start to think about the impact of language and cultural differences on achieving health equity. Many of you may have joined in for Dr. Kathleen Milan's presentation last year, where she shared the findings from her PhD research and highlighted the differences in management and outcomes for people with aphasia post-stroke who require an interpreter. So, if you weren't already convinced from your own clinical practice or research, I hope that thinking about those stats and also thinking about these actual and potential inequities in healthcare for people with aphasia from culturally and linguistically diverse backgrounds convinces you that cross-linguistic aphasia management is an important topic for us all to be thinking and talking about. A few final comments before we launch into all of the results. This research does have an Australian focus. It was conducted with Australian participants, and so with that comes the fact that we do have a public healthcare system here in Australia with access to highly trained interpreters, and we have a national organisation that is responsible for accrediting interpreters here in Australia, NAATI. Also, my work focused on people with aphasia from migrant and refugee backgrounds, not First Nations people. But given that this work is centered around collaboration with interpreters, some of the findings and recommendations may have some relevance to other populations where we're working across languages. And finally, this is qualitative research, so it would be remiss of me not to acknowledge my own position, particularly given the topic that we're discussing. So I am a monolingual English speaker from the majority culture here in Australia. However, my other position in this is as a speech pathologist working with people from culturally and linguistically diverse backgrounds and working with interpreters. So today I'll share the results of the 3 studies that were involved in my PhD research. So we had a scoping review, in-depth interviews, and co-design workshops. And I commenced and completed this PhD whilst I was working on an acute stroke unit at a tertiary hospital in Sydney. And so I had a strong motivation to produce outcomes that would be meaningful for clinicians and hopefully in the long term start to make a difference to the care and outcomes for people with aphasia from culturally and linguistically diverse backgrounds. And so from this work, I think we have been able to provide guidance and clearer structure to both speech pathologists and interpreters when they're collaborating to adapt and deliver aphasia therapy in different languages. If we start with the scoping review, this explored aphasia rehabilitation when speech pathologists and clients don't share a language. We had 20 papers included in that review, and essentially the take-home messages were that there's no research on therapy when it's delivered with or through an interpreter. And most of the results in this space, most of what we know, comes from the perspective of speech pathologists. And there's been little to no involvement of interpreters or people with aphasia. We also looked at that data with the question of what do speech pathologists think are the challenges of cross-linguistic aphasia management. And first and foremost, there's the issue around gaps in education about culturally and linguistically diverse aphasia and working with interpreters. There's a gap in knowledge about the linguistic characteristics of other languages. And it's not surprising considering how many languages are spoken here in Australia. And then there's a lack of culturally and linguistically appropriate therapy materials. We do still have difficulty accessing interpreters. Like I said, there are limitations and a lack of research on culturally and linguistically diverse aphasia, which in turn means that our clinical guidelines don't always have the kind of specificity and detail and instruction that we might be seeking to help inform our practice in this space. One of the key findings of that scoping review was that the voices of interpreters have not been represented in the literature. So we set out to address that in this second study, where we conducted in-depth interviews with interpreters, and we were asking the question, what is the experience of interpreters collaborating with speech pathologists to support the provision of aphasia therapy? And we used interpretative phenomenological analysis to look at that data. In terms of who we interviewed, we had 8 participants in total with a range of experience. On average, 15 years experience working with an interpreter, but you can see we had some earlier in their careers and some very established in their careers. We had quite a nice mix of languages across our interpreter participants, and also more than half of our participants had worked with speech pathologists on more than 30 occasions, but again, some with less experience as well. From that data analysis, we ended up with a number of group themes, and those themes fit into 3 top-level categories, which were that interpreting for aphasia involves non-standard practices for interpreters, that collaboration between the speech pathologist and interpreter for having that mutual understanding of the critical elements of both aphasia therapy and interpreting. And additional knowledge and skills are required to manage interpreting for aphasia. And that's on both sides. So the interpreter as well as the speech pathologist both need extra knowledge and skills. So we looked at that data with a similar kind of question around what interpreters think are the challenges in this space. And for our participants, education was an issue for them as well. So they felt that they had limited knowledge and education about aphasia. Most of them learned on the job what aphasia was, and they lacked confidence interpreting disordered verbal output. They found that the variability in briefing practices amongst speech pathologists could make things a bit tricky. And there was a lot of uncertainty around providing feedback to the speech pathologist about the person with aphasia's communication. And for our participants, that really linked to their code of ethics and their scope of practice and wanting to make sure that they were adhering to that. And somewhat related was this idea around discussing culture can be quite tricky. Obviously, there are going to be times that we do need to talk about culture because of how it may or may not be impacting and influencing communication. But some of our participants talked about how they worried that it might lead to perpetuating stereotypes or overgeneralizing. So navigating that was a bit difficult for them. Obviously, cultural and linguistic diversity is going to impact on interpreting, but even more so in aphasia management. So, for example, in a scenario perhaps where the interpreter is unable to understand something the patient says, trying to tease apart, is it because of a paraphasia, a neologism from their aphasia, or is it because of a dialect difference and the interpreter doesn't know that term in the patient's other dialect? And finally, there's just not enough time for this work, that speech pathologists often don't book a long enough session, or they don't book enough time before and after for briefing. Overall, our interpreter participants were telling us that they're often coming to these sessions with little to no training or knowledge of aphasia. And what we're asking them to do is outside of their usual way of practicing, which can be stressful, and they have concerns about adhering to their code of ethics and staying within their scope of practice. So the scoping review and the interpreter interviews were really invaluable for elucidating and synthesizing the challenges of cross-linguistic aphasia therapy and getting, a clear understanding of that. But we then wanted to shift focus and start to come up with some solutions. And to do that, we adopted a co-design approach. And there's two publications related to this co-design work. We brought together 4 speech pathologists and 4 interpreters. The majority of participants were female, but we did manage to get 2 male interpreters. Our interpreters predominantly worked in-house, meaning that they were employed directly by the hospital or the health service. But we did have 1 freelance interpreter, which was great to be able to get that different perspective as well. And our interpreters and our speech pathologists lived and worked in New South Wales, the Australian Capital Territory, and Victoria. And if we have a look at the languages spoken by our interpreters, again, we've got quite a nice mix. The workshops took place online over Zoom, which, allowed us to be able to bring together that mix of participants who worked in different areas and different health settings and institutions. We ran 5 co-design workshops in total. The first workshop was very exploratory and generative, so lots of group discussion about the challenges and the possible solutions. That discussion took a lot longer than we had anticipated. So we then continued that discussion into the second workshop so that we could make sure that we discussed all of the challenges and really being able to get into the really rich detail about them. And then in workshop 3, our co-designers looked at all those solutions that they had proposed and rated the potential impact as well as feasibility of those solutions, which would obviously vary depending on where they worked and what their experience was. And in the 4th workshop, we went one step further with those solutions, and our co-designers started to consider the implementation of those solutions. So who might need to be involved and what role they would have to play to support successful implementation into practice. So these first 4 workshops are considered the generative phase of co-design. And one of the proposed solutions in that very first workshop, in workshop 1, was this idea about a tool that speech pathologists and interpreters could pick up and use that guided and instructed them on how to do this work together. So that was something that we developed over the course of those 4 workshops. I drew on all of our co-designers' suggestions about solutions and what should be in such a document, as well as incorporating what's already out there in the literature, particularly in the interpreter-mediated aphasia assessment space, the broader literature about working with interpreters, as well as a couple of tools that are already out there about speech pathology and interpreters. And that got presented back to participants across the workshops for further refinement and feedback on what else needed to be in there or what needed to change. And so we ended up with this tool. So in the 5th workshop, we actually started to evaluate that tool, and we did a pilot evaluation of the tool that we developed. And I'll get to that tool in a few slides' time. But in terms of the outcomes from those first 4 generative workshops, our co-designers suggested a total of 23 possible solutions that could target the challenges associated with training and education, appropriate therapy materials for different cultures and languages, the briefing process, the debriefing process, accessing interpreters, and also that big challenge of time. And if you're interested, there's a lot more detail about those solutions in the paper. And in terms of who needs to be involved to implement these solutions into practice, our co-designers felt that in addition to the individual speech pathologist or interpreter, our universities, our government health departments, our local health services, as well as our professional associations, all have different roles to play in implementing these solutions. That brings us to the La Trobe University Aphasia Therapy Collaboration Tool for Speech Pathologists and Interpreters, or the LTU-AXPI. I think you can see why we gave it an acronym. It's a bit of a mouthful. That tool is available as a supplement to the final paper, which is open access online, so anyone can look at that. So I'll talk to you a little bit about the content of that tool, what ended up in the tool. It's about maybe 7 or 8 pages in total. There's a section targeted at the speech pathologist for their preparation for the session. And the information in there talks about the role of the interpreter. So really trying to highlight to the speech pathologist that this is considered a complex area of specialised practice for interpreters. And what we're asking the interpreter to do is different to their usual way of practicing. We also wanted to flag the difference between an interpreter versus a translator. Here in Australia, they are separate certifications, and not every interpreter is a translator, and vice versa. We also offered some guidance around how much time to allocate. So we're talking about double the length of a session if it was in the same language, as well as that extra time before and after for briefing. We've included ideas for some of the patient demographics to consider, as well as some structure around how to conceptualize cultural elements, and then some dot points about some information about the target language to try and find out. So, for example, what's the sentence order? What's the orthography of the language? So obviously some of this information might be discussed in the briefing session and obtained from the interpreter, but starting to get the speech pathologist thinking about it, and maybe finding some of this out beforehand. Then there are, recommendations about when the speech pathologist is actually booking the interpreter through the booking service, what information to provide to maximize the chances that an adequately trained and prepared interpreter gets allocated for the session. We have a similar section for the interpreter to support their preparation. So similarly, we've got information about the role of the speech pathologist. So talking about the role of the speech pathologist in aphasia management and how reliant the speech pathologist is going to be on the interpreter's knowledge and expertise about the target language and culture. There's also information there flagging how in aphasia, we're not necessarily just targeting spoken language, we're also working on written language. So trying to get this idea to the interpreter that, we may need to be doing some written language. So, flagging to them that there might be small amounts of written translation involved, but, nothing as formal as, full translation of pages of content. And then there's some suggestions about what the interpreter could start to consider before the session. So if they have been able to be informed that it's an aphasia session, reading up on that, familiarising themselves with the kinds of presentations and errors that they might encounter, thinking about whether there's any features of their language and culture that might be relevant to inform the speech pathologist of, and also thinking about and preparing themselves for how they might render into English disordered verbal output associated with aphasia, or how they might describe it if they can't interpret it. And then there's also some more targeted advice around briefing and debriefing for the interpreter. And then thirdly, we have this joint section on the bid process specifically for aphasia therapy. And for anyone who's unfamiliar with the BID process, it stands for briefing, interaction, and debriefing. It's a very well documented, recommended process about the processes that we should follow when we are working with interpreters. So there's a number of chapters in textbooks and papers from Henrietta Langdon that talks about the BID process. And that final section is really where, that all that preparation beforehand on behalf of the speech pathologist and the interpreter really comes to fruition when they meet in the same space to do a briefing session. So we were pretty happy with our tool. We thought that it had everything that we wanted in it, but we wanted to test it out. So in that final 5th workshop, we divided our co-designers into pairs, so one speechy, one interpreter. And so then we actually ran 4 separate workshops to test out the collaboration tool using role play. We created 4 hypothetical case studies that matched with the languages and backgrounds of our interpreters. And we fleshed out that case study in the background using information that's available online about different migrant communities here in Australia. And then we used AI to generate an image and a name. And then our pairs used our collaboration tool as a guide for a briefing session, as if they were about to go in and deliver an aphasia therapy session of VNest or verb network strengthening treatment for that patient. And you may be wondering why we chose VNest. This was, it was a pilot study. It was the starting process in the evaluation. But given that we really wanted to get into the nitty-gritty of the adaptation, we decided that by choosing a therapy approach that targeted verbs and worked at the sentence level, we'd hopefully be able to get more insight and more information about that adaptation process when we're factoring in grammar as well as semantics. So for that final study of the pilot evaluation of a co-designed tool, our research question was, can the tool be used to support speech pathologists and interpreters collaborating during a briefing session to adapt aphasia therapy? And if so, how? We recorded the role play, and during any natural lulls or pauses during the role play, I would ask participants how it was going, how they were finding it. And then at the end of the role play, we went through a more structured interview that asked about their general thoughts and reflections on the briefing and the adaptation process and using the tool, as well as the challenges they were still facing, what they thought the benefits of the tool were, also what they thought about how the tool would go in the clinical real-world setting, whether there were any extra skills or knowledge they thought they might need to use the tool and adapt therapy, what they might do differently next time, and if they suggested any changes to the tool. And we used framework analysis to look at that data. And so that analysis gave us 4 key themes, and they were that mutual engagement promotes active and productive collaboration. Probably no surprise to anyone here, time is a limited resource. Engaging in adaptation can be complex and does require additional skills and resources. And the tool, the LTU Axby, does have multiple benefits. For today, I'm going to focus on these final 2 themes about adaptation and the benefits of the tool. So starting off with the adaptation piece. The first sub-theme within here relates to the idea that it really is crucial that the speech pathologist and the interpreter review all the therapy stimulus to ensure that there's cultural and linguistic appropriateness and equivalence. And that by doing this in the briefing session, we then avoid having to stop and pause during the session, put the client on hold, have side conversations to try and come up with suitable adaptations on the spot. But in addition to identifying and excluding any stimulus that might be inappropriate for the language or culture, we also need to take the time to generate suitable alternatives so that we've actually got sufficient options to use during the session. And to do that, the speech pathologist is going to rely on the interpreter to inform them of a mismatch between the therapy approach or the stimulus and the target language and culture. But not all interpreters may feel comfortable or confident to volunteer this information. And again, that probably relates back to code of ethics and scope of practice. So speech pathologists may need to be quite direct in asking for this kind of information. And also, interpreters are better able to advise the speech pathologist on adaptation if they can actually have a clear understanding of the purpose and the process of the therapy, what it is that we're actually trying to achieve. However, to do this, the speech pathologist needs to have a thorough knowledge of the therapy approach to be able to clearly explain the technique and its components. So, like I said, we chose VNest as our exemplar therapy. And 3 of our speech pathologists, most of whom were very experienced, did report that explaining the therapy and process to the interpreter was more challenging than they had anticipated. One participant talked about that she felt like she was just kind of getting a bit lost in her explanation. And related to that, there's this concept about metalinguistic knowledge and vocabulary are required to discuss languages and discuss language differences, particularly when we're working at the sentence level and we're talking about things like thematic roles that go with verbs, the different sentence structure, how sentence organization might change meaning, which makes things even more difficult. So we can see from those sub-themes that this adaptation piece is complex, but the good news is that we have the LTU AXB to help guide us in this. And I'm going to use participant quotes to demonstrate the sub-themes within this final theme about the benefits of the tool. So first and foremost, our participants felt that doing a briefing with the support of the tool helped them to feel more prepared and confident for their session. One speech pathologist talked about that the tool was there to make sure that she had prompts, that she'd covered what she needed to cover, because sometimes you can get swept up in the session and you don't stop to ask critical questions. Another participant talked about, and this was an interpreter, that it helps to prompt them to think about what information is missing, what they need to know or should know before they go into the session. And this was another really interesting quote around, that it's a tool that we're following. So it takes away from the personal side of things, and it's not me questioning the interpreter's level of experience, but it's there on the tool and it's something that we go through, which I think for me makes me think about, building rapport and building partnership with the interpreter. I loved this quote from one of the speech pathologists and how she said that she felt really confident about entering the session after using this briefing, and that she didn't know that she could feel this good going into a session with an interpreter for another language. And likewise, one of the interpreters commented that with all of that explanation from the speech pathologist, it was very clear for them and they could imagine what the session was going to look like. Another benefit of the tool was that by taking the time to do this adaptation, we will end up with more personalized and effective therapy. So the materials are going to be more relevant to the client. The speech pathologist isn't going to be taking in inappropriate stimulus or something that's not going to make sense in the language. And so ultimately, she's going to have a more effective session. Going through this process of adaptation ultimately is going to help with developing therapy resources. So resources that you can use not just with that client in that session, but maybe that client in future sessions or future clients, perhaps from the same language or cultural background. One of the speech pathologists was talking about like that, yes, this does take time. It is a time commitment, but now she has these resources, for example, in Mandarin for the verb deliver. And so she's building her resource portfolio in different languages. Another participant talked about that maybe in that first briefing session that they could take the time to work through and choose a whole bunch of verbs that would be suitable for the language. And so that in the next session, they've got plenty of options to go through. And that really builds and leads to this final quote here that I think is interesting food for thought. So this speech pathologist raised the possibility of rethinking how we book and use interpreters. And perhaps, she says, instead of seeing the patient that day, is your time better spent, or is the next half an hour better spent setting yourself up for the next month of sessions with the interpreter? So this idea about we book the interpreter specifically related to a client, but we don't necessarily see the client at that time, but we commit this time to adapt and prepare resources that we can use for our future sessions with them. And then the tool also helps to improve the partnership between the speech pathologist and the interpreter, building rapport, feeling more comfortable with the interpreter. And then one of the speech pathologists also commented about that the interpreter seemed as invested in the pre-briefing session as she was, and that they were asking questions that she might have otherwise missed. And for me, when I looked at this sub-theme, it links really nicely with the work from Peter Roger and Tanya Crawford, where they have a great paper about building trust between speech pathologists and interpreters. So for me, that aligns really nicely with that. And then finally, obviously, it's not possible to know everything about every language or culture that we're going to encounter, but gradually over time, each time the speech pathologist engages in this level of discussion and adaptation with the interpreter, they will be learning more about different languages and cultures, and it's going to increase their knowledge. So one of the speech pathologists mentioned that, she found this super helpful and she felt like it added to her knowledge because before this interaction, she didn't know anything about the Sinhalese language. There were some suggested changes to the tool. So several participants talked about the need perhaps for a dot point checklist of the content that should be covered in the briefing session, that, maybe was a little bit hard at times to find information within that larger, dense document. So we put together this 10-point checklist with the idea of maybe it's something that could be printed out on a lanyard and then you refer back to the larger document as needed. And then given the challenges around explaining therapy approaches, we started wondering whether, is it worth considering incorporating something like the RTSS, the Rehabilitation Treatment Specification System, to give some kind of scaffold and structure to the speech pathologist's explanation of the therapy and, what we're doing, how it's working, what it's targeting, what we're manipulating. So in summary, our scoping review highlighted the challenges of cross-linguistic aphasia therapy from the perspectives of speech pathologists, and it also highlighted that there's a lack of research on interpreter-mediated aphasia therapy. But then our interviews with interpreters helped to shine a light on the interpreter experience and really reinforce that this is a complex area of specialised practice. And that is something that has been in the literature, but it was great that we can finally have that directly from the interpreters themselves. And then our co-design workshops offer new ideas and extra detail about previously proposed solutions, as well as a tool that speech pathologists can start using now. And I think as well that extra detail about the possible pathways to implementation of solutions, that has the potential to serve as a bit of a research agenda for the next stages of research in this space, with the benefit of having actually been co-designed through input from clinicians who have insight into real-world practice. However, there's still a missing piece of the puzzle. I am just one speech pathologist and researcher in, a line of researchers that have been talking about this topic for 20, 30 years, but it still continues to present challenges for us. So we need to maybe think about how we do things differently. And for me, as I was pulling my thesis together, the most significant and overarching finding is that there's a need for a whole of system approach to address these challenges of cross-linguistic aphasia therapy and ensure equity of service. So yes, clinicians can strive to follow published guidelines and recommendations, use tools like what we've presented here today, but there are much larger system level issues at play that really are going to be needed to drive meaningful, widespread, and sustained change. So, our universities have a role to play in consistently including content on aphasia in culturally and linguistically diverse clients, multilingualism, about cross-cultural practice, how to work with interpreters so that we are better equipping our speech pathology workforce. We also need strong policy from our government health departments. And, some of that does exist. So here in Australia, we have the Multicultural Access and Equity Policy Guide. That policy needs to then be implemented at a local health district level. Again, some states are partway there. So New South Wales Health, Queensland Health, Victorian Health, they all have policies on working with interpreters. But there still seems to be this gap between policy and practice. And so perhaps what we need are some different mechanisms to ensure accountability for compliance with policy, which then might support us to change our systems to support compliance with policy. So for me here in Australia, I'm thinking about our hospitals go through an accreditation process against the National Safety and Quality Health Service standards. Maybe there needs to be something in there about how we are providing care to clients from culturally and linguistically diverse backgrounds and how we're using interpreters. Maybe our National Stroke Foundation audit should be capturing information not only about whether or not the client needs an interpreter, but whether or not one was used, what the delays were, those sorts of issues. And then our professional associations, Speech Pathology Australia, the National Australian Accreditation for Translators and Interpreters, they could also be involved in training, education, clinical guidelines, advocacy. But ultimately, the responsibility for addressing service inequities for people with aphasia from culturally and linguistically diverse backgrounds doesn't rest solely with clinicians or their managers. We need a system-wide approach to tackle this disconnect between overarching government policy and clinical practice. So that's me done. All of those studies are available online and the last two are open access, but feel free to get in touch.
Fantastic. Thank you.
Thanks, Beck. I'll stop my share.
Okay. So we do have a couple of questions. So the first one is, it's a wonderful talk and a wonderful body of work. Thank you. So there's two questions. Do you see the tool evolving over time? And what factors will influence any of its evolutions?
Yeah. So yes, there were some suggestions for things that we could do differently to the tool and, that we've started thinking about. Obviously, this is, tested in a very controlled research environment. So it would be great to actually pilot it in a clinical health service and actually see how clinicians use it and what they think of it. I'm also thinking about this is specifically for aphasia therapy, but potentially it could have applicability to other acquired communication disorders, or even maybe thinking about a process and a structure for how perhaps other disciplines might approach how they work with interpreters and how they adapt therapies for other languages and cultures. Yeah.
So I can definitely see that first half, where you're presenting like the guidelines and sort of setting up that relationship being adopted across so many different healthcare interactions, right?
Yeah, absolutely. Yeah.
Yeah. So given the systemic factors that are associated with the tool like this, what do you think is the best path to facilitating that implementation?
Oh, the best path. I think, like I've talked about, and I do believe it's not just the responsibility of the speech
Mm,
pathologist. But I mean, I know when I reflect on my training and my earlier practice, I didn't receive any training on how to work with interpreters. So I really do think that awareness and education and knowing about these processes and being aware that a tool like this exists
mm,
does help give clinicians a starting point and some structure. Um, but then if we can try and, incorporate it and get it out there through universities or associations. But then I also think like time is always the biggest issue. So, and I think that's where maybe this concept of like thinking about accreditation and mechanisms for monitoring how we actually provide services is this recognition that this kind of work and actually providing equitable care to people from diverse backgrounds does take more time, and that needs to be recognized and reflected when we're
mm.
actually looking, like on the front line at caseload allocation and management and that kind of thing.
Yeah, I agree. And I think, another factor to that is for health services that don't have in-house interpreters,
Hmm.
you have to pay for them, right? And trying to internally justify, spending the time to set up the relationship, even though you know it's going to be beneficial for your client, but there's like this pull internally about,
Yeah.
I'm not actually seeing this person, but I'm just setting this up for them. So how do I justify having to pay for
Yeah.
that? Yeah.
Oh, absolutely. And like, obviously a lot of this was in the context of the public health system, but
Mm,
obviously there are lots and lots of other environments where speech pathologists work. Like even thinking about, with the NDIS here in Australia, where there's a budget and there's a limit, and you've also then got to find space in the budget for interpreters.
yeah.
But it was interesting. Like our participants did talk about earlier on, like, oh, realistically, you couldn't spend this much time, but like their ideas kind of shifted about, oh, actually, this is a worthwhile investment. Like, yes, it's kind of like
Mm.
a rethinking how we approach it, like this idea about you invest this time at the beginning to then get more effective and productive sessions ongoing. But it is always a tension if there's,
It is.
the
And I
cost.
think for clinicians, that's going to be part of the implementation of the tool, right? That
Yeah,
tension around the mind shift.
yeah, yeah, absolutely, absolutely. Yeah.
Yeah. So another question is, I wonder about the voice of people with aphasia and how was that considered in their experiences or in the co-design of the tool?
Yeah.
Mm.
And this was something that I had wanted to do in my PhD. So the study where we interviewed interpreters, we had designed another study alongside that, interviewing
Mm.
people with aphasia from culturally and linguistically diverse backgrounds. Um, but unfortunately, within kind of the time constraints of a PhD, we learned that you need a lot of extra resources and processes to include people with aphasia from different language backgrounds. And so, unfortunately, we had to abandon that study, but it is still
Mm.
something that I would really like to include because at the moment, we've got, the voices of speeches and interpreters, but I think we can learn a lot from actually asking people with aphasia who received therapy through an interpreter in a different language or different languages, what it's like for them and how appropriate it was for them and how they find
Mm.
that process. So that is still a big missing piece of the puzzle. So it was a big disappointment for me to have to let that study go, but it was also a huge learning process.
Mm.
And hopefully, if I ever do get to do that study, I can kind of take some of that learning into it and we might have more success with recruitment.
Yeah, I think there's always future work to be done.
Yeah.
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 Yeah. And this is a really nice grounding point for
Yeah.
it. Yeah.
Yeah. Yeah.
I think we've got time for, yep, time for one more. So, this is an interesting question. Do you think the idea of what is fair is part of the problem? So, if we think about being fair, it means giving everyone the same clinical time, then patients who need interpreters or culturally and linguistically diverse patients are always going to be disadvantaged, right?
Mm.
So, do we need to work on what is fair and defining fair? Is it the same as opportunity?
Oh, that's a good question. I mean, to me, this is the reality of what we're talking about when we talk about equity,
Mm,
is, you
mm,
know, to have the same, if we want patients to receive the same, to get the same outcomes and get the same amount of input, then it is going to look different. Yeah, you're right. People from culturally and linguistically diverse backgrounds will technically need more time. Um, but I think we still don't know for sure if we're still going to get equal outcomes from that.
mm.
So, look, I don't have a perfect answer, but I think that's what we need to be thinking about, this idea about what does equity look like and being honest about, I mean, for me, I think about, if I do an hour session with a person with aphasia in English, they're getting an hour. I mean, we could get into the nitty-gritty about what the actual dosage is and how many turns, blah, blah, blah. But whereas if I do a session for an hour with a person with aphasia in Mandarin, they're kind of getting half the dosage, really, in a way, because the time that's taken for everything to be said twice. So, yeah, no perfect answer, but I think we just need to be aware of what the patient is actually getting.
Yeah,
And yeah, it's a hard
yeah.
one.
It is hard.
Yeah.
Totally agree.
Yeah, and
Totally
we're
agree.
constantly struggling with that challenge across so many areas in clinical work about, what the best practice guidelines are and what we, desperately, passionately want to provide and what we can
Yes.
within the system. So
Yes,
this is just another piece of that.
it is. Yeah, absolutely. Well, thanks again. I will just bring up my slides. Let's have a look. Mm, there it is. Okay, lovely. So thanks again, Chelsea. That was a really fantastic presentation. So today's seminar has been recorded and will be available soon on our YouTube channel, where you can also have a look at our full library of past sessions. So feel free to share it with colleagues or catch up on any seminars that you may have missed. To stay connected to the Aphasia CRE, you need to follow our CRE blog on Facebook or on LinkedIn, where we regularly post updates about research, upcoming studies, and opportunities to be involved in our community. So our CRE seminar series returns in May with Dr. Monica Norvik. So a big thank you again to Chelsea, our speaker, and to all of you for joining us. Take care, and we will see you next time.